All right, welcome everyone back to another virtual shadowing session at Hearts for Health. Today we have another PA on, Saif. He's a PA practicing emergency medicine. We have quite a few in emergency medicine, so for y'all who are excited to hear more about emergency medicine, this is your time. This is the session for you. I do have a few reminders though for y'all, especially if you're new to our virtual shadowing program or to the just general idea of virtual shadowing. So at the end of each one of these sessions, we do have a Q&A for our speakers. If you have any questions for Saif or any future speakers, please do feel free to type them in the chat. And I'll be reading them out at the end of the session today when we have our Q&A. Also, if you want to stay updated with future shadowing sessions, we post them on Instagram through our flyers. And we also have a listserv where we include those flyers, but just send them out weekly over email. Either one is a good way to stay tuned with us. And obviously, through Instagram, you can feel free to follow us. To hop onto our listserv, to our weekly email listserv, you can subscribe on our website. We have a subscription form at the bottom of every page on our website. So if you scroll all the way down, you'll see a subscription form on the left-hand side. Fill it out, click submit, and you'll be good to go. If you have any questions outside of what I mentioned or any questions about our upcoming programs, the programs that we're going to launch, our volunteering programs, our mentorship programs, that will be coming up this fall. We've had a couple of cycles with those programs, and we'll be launching them again this fall. We just have them on hold during the summers. Feel free to email us, and our email is community@hearts4health.org. We're happy to take any questions there about our virtual shadowing program or any other programs. With that said, though, feel free to take it away, Saif.
Great. Thank you very much, Michael. Hi, hello. How's it going? My name's Saif. Saif like sapphire or saphinus, whatever floats your boat. I am a physician assistant working in emergency medicine here in Canada. I work in the Scarborough Health Network, and I am happy, excited, and honored to be here today to talk about emergency medicine and my career as a PA, and talk about me, because what's better than talking about myself? I got a little presentation here that I will share. Okay, you can see that? Thumbs up. Perfect. So, about me. I did my undergraduate degree in a Bachelor of Science in Kinesiology. So that's bones and muscles, how the body works, how the body moves. It was a really good base program, in my opinion, to learn about the body in general and some basic things that can go wrong with it, and more focused on the MSK side, but still, I really enjoyed learning about the body and was always interested in it. So it was a good place to start for me. And then after that, I immediately went to the bachelor. We have 3 programs in total in Canada. We have the program in Toronto, and then we have a program in Hamilton, which is the McMaster University. And then we have a program in Manitoba, University of Manitoba. And I applied to McMaster, and I got into there. And it is a 2-year program here in Canada. We have 1 year of didactic learning and 1 year of clerkship. Didactic is in the classroom. Clerkship is you're doing placements in various hospitals in various specialties. I did 4 years of undergrad and then 2 years of being in PA school, and I started working after that. Outside of that, I also, during my time in school, I joined the Canadian military and was training as a medical assistant. I did that for about 4 years. That gave me some unique experiences and unique knowledge that was a bit more geared towards battle medicine, they call it, or more field medicine. Really, really fun, really interesting, novel experience that you don't often get to go through, but I enjoyed it. I also lifeguarded. So taking care of people was something that I kind of was being responsible for people's well-being and their health was a responsibility that I was comfortable with as a lifeguard. And outside of health and taking care of people, I was also on the McMaster dance team and would perform and compete in competitions. And that is one of my passions. I think dancing is the essence of life, or something like that, and that we all should dance a little bit more every day. That is me. My career is as a physician assistant. I've been a PA for the last 2.5 years now. And this is the definition I think encompasses what a PA is to an appropriate degree: a highly skilled healthcare professional educated in the medical model who practices medicine under the direct or indirect supervision of a licensed physician within a patient-centered healthcare team. It's a bit of a mouthful, but I tried to squeeze in all of the important stuff into one sentence. So PAs, physician assistants, aren't, health or medical assistants. They're not scribes. They're not there to take your notes or handle your paperwork. They're trained in medicine and they are supposed to practice medicine. And so they should be doing similar things that a doctor is doing. They're trained under the medical model, which would be different than the nursing model. So we're trained under the same model that doctors are trained under. And we can practice medicine under direct or indirect, meaning the doctor doesn't have to be there all of the time while we are performing medicine or seeing patients. They can be somewhere else in the hospital or somewhere else in the clinic, or not even on site. They can be somewhere else entirely and be available by phone, but you are in some way under supervision. The direct more so comes for things that require the doctor to also be there. So that would be things like major surgery or anesthesia, where we are not trained in those things. So if someone needs their appendix out, we can't do that by ourselves, but we can help the doctor by assisting them, whether that's opening the person up or stitching them up or holding tools, helping with the procedure, being a first assist. So that would be more a direct supervision. And then, it's very patient-centered healthcare team. So we can work within the team. We can interact with other healthcare professionals as well, and we often do. So that is what a physician assistant is. And if there's questions along the way, Michael, I'm sure you'll let me know. So feel free to interrupt. I'm very informal, and I can go in any direction that people would like to go to. Why become a PA? It's a great question. Thanks for asking. I think that there are many different reasons to become a PA. I think there's many different reasons to go into healthcare. For me personally, I wanted to learn more about the human body. I have one, you have one, we all have one, and we use it every day. And it'd be cool to know what it does, why it does that, and if it goes wrong or if it makes a mistake, which it often does, how can we fix it? How can we remedy that? And I didn't have, some people have a story of there was major health problems in their life that inspired them to go into medicine. I can't say that I had that. I more so just had a general interest in the human body. I also knew I wanted to take care of people or help people in some way. And I think almost every job helps people in some way, whether that's direct or indirect. Like someone who is a barista is helping people by giving them the most important thing of the day, which is their coffee. That's an important job. A garbage collector, if we don't collect our garbage, it piles up and then the streets are filled with garbage. So every single person is helping people in some way, but I chose to provide it in a medical because I trust in medicine and the human body. The very common question people ask is why PA and why not MD? Why not the medicine? Why not become a doctor? And one of the reasons for that is the length of schooling. So I am personally a very experiential learner. I like to learn on the job. I like to learn by practicing, learn by doing, and not learn by reading or watching or listening. And so I wanted to do that as quickly as possible. So a 2-year program got me to working much sooner. I'm turning 27 this year, and I'll be working for 3 years by 27. Versus if I went to med school, I would have at the very earliest graduated at 27 or 28 probably, if I did family medicine and took the shortest amount of time to do schooling. But it could easily have been, much older if I went to more of a special field. I also really enjoy working as a team. As a doctor, if you wanted to, you could work completely by yourself. You can work in a clinic with you and just one other nurse. And that is a reality for some people. Or in the emergency department, you could be just the only doctor there at any point in time. On night shifts sometimes, or in a rural hospital. But as a PA, you're always working with somebody in some capacity. You always have somebody that you can talk to or rely on, or ask questions, or ask for support, or ask for a second opinion. And I like that. I don't necessarily need to be the final authority or the top of the pyramid, but I'm happy part of the team and work collaboratively. And I think some people aren't okay with that, and that's okay. If your personality or you're more inclined to be the leader and be the higher on the pyramid, then that's who you are, and you should go towards something that does that. I think PAs have an opportunity to also be leaders as well, in their own field and in other aspects of the career or other aspects of healthcare, but that's much more earned over time compared to just being the de facto leader. Sometimes if you have the MD under your name, not always. I also really am interested in a lot of different things. I like to try different things. I don't like to limit myself to one thing in terms of learning. And so I wanted to be able to switch to different specialties. It's actually something that I did that I will go into in a little bit later. But PAs, physician assistants, are able to switch specialties. I know in America, they do have residency programs for PAs. We don't have that in Canada. So we don't technically specialize. We are always general practitioners. We can switch to a different specialty if there is a job available. So there's the opportunity to switch. There's not a guarantee, but I know many PAs that have switched, including myself. I also think that, at least in Canada, we have a bit of hard time with we have a lack of access to medical care, and we have long wait times as well. And I think physician assistants are a great solution, or a great potential solution for that, because we can help patients be seen faster, and we can also increase access to care by, if a family medicine doctor can only see, let's say, 1,000 patients, a very experienced PA can increase that number from 1,000 to 1,500 or even more by adding to that practice. Instead of making their own practice, they can become part of one to care in that capacity. And the same thing with emergency medicine. If there are people who have very complex lacerations that will take about an hour to do, a physician assistant could do that while the doctor is seeing very, very sick patients that can't wait an hour. So it's a collaborative approach that I think is actually beneficial for patients and for the healthcare system. How do you become a PA? So at least in Canada, I'm going to speak very Canada-centric here, selfishly. You do your undergraduate degree, you apply to one of the 3 Canadian PA programs, you get accepted, fingers crossed, and you do the 2-year program, then you apply to jobs. So it's relatively simple. There's no tests that you have to write. There's no PCAT. Again, fingers crossed, that never shows up in our reality, but there's no qualifying exam that you have to write. There are interview aspects and parts of the admission process that you have to go through, of course. For myself, it was a supplementary application and then a multiple mini interview. And they looked at my GPA. Those are the 3 things that they looked at. And then other schools require a certain amount of community hours, or they may require a written supplementary application or a personal statement, things like that. But for me, I just had to do the interview and supplementary application. And then you do your 2-year program, which is, I would describe it as condensed medical school. So instead of spending 4 years learning, you condense it all down to 2 years, and you focus on the high yield stuff. I don't think PA school teaches you everything you need to know, but it gives you the tools to be able to learn on the job and to be able to learn every day, and to be part of a healthcare team and provide value and purpose by using the tools that you've learned to perform medicine. And then applying to jobs. So in Canada right now, there are more jobs than there are PAs. Granted, we have a small amount of PAs. I think we have less than 1,000 in Canada, whereas in the US they are widespread. But so there's more hospitals and clinics that are now becoming aware of what a PA is and what they can do. And so there are a lot of job openings that are going unfilled because the standard for what a PA wants has increased as the demand for it increases, but the supply has been relatively stable. We're waiting for more government funding to make more positions and more spots in the PA programs here in Canada. In Ontario, at least, we graduate about 50 per year. So it's a pretty small cohort of people. Okay, So yeah, I started my career in family medicine. That was my first job. I worked there for about a year. And I didn't think I was going to work in family medicine while I was in school. It was not something that I envisioned for myself, but through the interview process and talking with the doctors that I would have been working with, I was sold and thought it would be a great place to start my career. So one of the reasons was a wide variety of medicine. I think, like I said before, I have an interest in a lot of different things. I didn't want to specialize into one thing and, pigeonhole myself into one specialty. It's harder to switch out when you are only well-versed in one field or one specialty. So I wanted to learn all different types of medicine. I also think family medicine is like the bedrock of our healthcare system. It keeps people healthy, whereas most other specialties will help people cure their disease or help them get better, versus family medicine keeps people healthy. And I think that more time, energy, effort, financial support should be put towards that, because I think preventative care is probably the most important care for our whole society or country or world, really. And yeah, there's you see all types of things. You see basic, high blood pressure, you see diabetes, heart failure, but also mental health and very interesting, unique cases as well that will show up. But, when they are too complicated, then you do end up referring that person to somebody else. So you don't necessarily always see those complicated cases through. And now if someone is too sick or too has their acuity, we would say, is too high, where they need immediate care, then we would send them to the emergency department. But in my clinic that I was working at, we did do some urgent care. So things that were not emergency, but maybe urgent, we did have hours set in the day where people could come in last minute to get seen as well. Lifelong follow-up, I think, was always something that I was partly interested in, as well as to be able to see someone over time. So patients that I saw at the beginning of the year, I got to see how our treatment affected them a year later. And I don't think not many specialties allow you to do that. Sometimes you see the patient for a week or two and then you don't see them again. If you, not all of them, your cardiologist might see you over and over again once a year. But whereas in family medicine, you're seeing a lot of these people all of the time. Very rarely do you see them just once. And so you get to build a relationship with them. You kind of become invested in their health. You go, come on, Jim, why are you still drinking those pops and eating the donuts? Or, or, hey, congratulations, you went from 10 cigarettes to 5 cigarettes. And that's a huge accomplishment. Or, congrats on your new kid. And now they're a year old. I remember when they were an infant. Like it's such a cool thing to be part of someone's life in that way. And yeah, become familiar with the patient's baseline. So like I said, family medicine is about keeping people healthy and seeing what healthy people are supposed to be like, or at least what someone with a chronic condition, where they should be, is also, I think, helpful to learn in medicine. So, a person with diabetes, if it's well controlled, this is what it looks like. Because in the emergency department, you don't see it only when it's well controlled. You often see it when it's not well controlled. But I wanted to get an understanding of normal as well, or what disease looks like when it's well controlled. There were some procedures I got to do while I was in family medicine, and those included biopsies. I did a lot of skin biopsies, intra-articular injections, so injections into joints, usually steroid injections, so shoulders and knees, and sometimes very simple lacerations. If something really simple came through my clinic was in a bit of a smaller town, and so if someone had a simple laceration, sometimes we would do that, but that was very rare. But we did a lot of skin biopsies, a lot of injections, and liquid nitrogen as well. If someone has a wart on their foot, we often use liquid nitrogen to burn it off. And that was another fun, common procedure that we did a lot. One of the main reasons I ended up working in that clinic particularly was because of the people. I really liked the staff that I met during the interview process, and I could see myself being friends with them outside of work. And to me, that's really important, to like the people that you work with. And so that really sold me. And I would encourage everyone to also prioritize that to some degree. Then I switched to emergency medicine after 1 year of working in family. I switched over to emergency for multiple reasons. One of that is it still had the wide variety of medicine, but now it had higher acuity. I wanted to become more comfortable with sicker people, sicker patients, and be able to know what to do with them. We had some people that would come into the family medicine clinic, but if they were too sick, we would just send them off. And I always thought, like, I wish I knew what to do for those people, or like what would be done. And so I also had that intrigue during school, so it never really left me. And in emergency medicine, you get to see, same thing, all of those same types of chronic conditions, but now in a more acute sense. So high blood pressure when it's too high, or sugars when they're too high, or mental it gets out of control, and people are having a harder time and more of in a crisis. Then you see them in those moments, and learn how to help them in those moments as well. So I liked the transition from knowing things when they're more at a baseline, and then seeing them when they're more at an extreme or in an emergent state. And there were even more procedures. I'm a big fan of procedures. I'm a big fan of fixing things with my hands. It feels very rewarding. It feels very purposeful, and like I can see the results as they're happening. And it's not often that you get to feel like you fix a problem right then and there in medicine. So I really like doing procedures for that reason. And so in the emergency department, I do lots of stuff like stitching. I put casts on people. I drain abscesses. I will reduce fractures sometimes, or reduce dislocated joints. And I don't do skin biopsies or joint injections anymore, interestingly enough. But so there are some procedures that you do more commonly in family medicine that you don't do in emergency medicine. But I feel like every day I'm doing a procedure, where in family medicine it was few and far between, I would say. The other thing is, in emergency medicine, even though there are a lot of common things that come through the door that you see basically every day, you don't know what it is. There could always be something that you're not aware of. So you are always hunting to figure that out. But if in family medicine, someone comes in and they have high blood pressure, they have high blood pressure. So you're just kind of managing that. Whereas someone comes in high blood pressure, you don't know why they have high blood pressure today. So you have to find that out. And I liked that. I liked puzzle solving. I liked, solving the mystery as to what they came in for today, and seeing if we can find the actual reason. And the difficult thing is that you don't often find the reason. Sometimes people come in with pain, and then you do your tests and you don't find an answer. But your tests show that there's no emergency as far as you know. And that's your job, is to make sure that the person is, not dying or not in an emergent case. And so you may not find an answer. You might have to refer them off to somebody else so they can find an answer. Or, if it's not dangerous, then you say that hopefully this gets better. If it gets worse, come back, but follow up with your family doctor otherwise.
Saif, we have a quick question from the chat. So a student was asking, what degree did you earn from undergrad? And I wanted to add to that, did you feel like it contributed in any way to your schooling later on as a PA?
Yeah, I earned a degree in a Bachelor of Science, specifically in kinesiology. And I think that it definitely did help in my career now. Kinesiology is very focused on the human body and human movement. So learning about bones and muscles, I had a very strong understanding of bones and muscles, I'd say. But McMaster's program was a science program. So we also learned about the different human systems, like the cardiorespiratory system and how that works, what can go wrong, and the neurologic system, the neuromuscular system, how that works, what can go wrong, what treatments are out there. We didn't go into the treatment aspect as much because they don't teach you medicine, right? But they do teach you how it works and the different steps and processes that happen within our body that help us function. So I really enjoyed that. I was always a fan of biology. I'm not a huge fan of chemistry. I like studying things that I can imagine, or I can have a visualization of. So even biology, getting down to the very cellular stuff, like microbiology, I'm not a huge fan of personally, or organic chemistry. These things, I did learn about them, but I didn't love learning about them. But I did love learning about, that my hand, like my hand's right here. I can see my hand. I know what bones are in my hand. I can feel my heart beating. I know what a heartbeat feels like. I can hear lungs breathe with the stethoscope, and I know like why they sound that way or why they sound different. I know like why, when you sprain your ankle, why does it get swollen, or what treatment could you do? Like, these are more, I don't know, to me, tactile things that I can learn. And that's just me personally, and what I'm interested in and what piques my interest. So it helped in that regard, to have a more bigger picture of the human body.
All right. Well, that's all the questions for now, but for those listening in, please do feel free to type in any more questions as we go through. Thank you, Saif.
Yeah, no problem. So dynamic environment, every day is a different day in the emergency. You might see some similar things over and over again, but no day is like another day. And there's no consistent schedule. Like you're not, the patients aren't scheduled into your day. You see them as they come. And then also my schedule where I work is constantly changing as well. Some people might hate that. I don't mind it right now, at least. I kind of like sometimes working in the afternoon, sometimes in the morning. I like having days off in the middle of the week, or working, 2 days and having 2 days off, or working 4 days and having 3 days off, and it kind of giving me opportunities to do different things on different days. Working in family medicine, I felt that the Monday to Friday 9 to 5 was getting a bit monotonous for me, and I know that some people would prefer that. They prefer schedule and consistency. I just was feeling kind of repetitive. And I think my personality is more of a sporadic, spontaneous, multiple direction personality. So it fit better, I think. Financial, I think money is important, no matter what they say. And working in emergency medicine, you typically do make a little bit more compared to family medicine. I also, with that being said, I also moved to a city that had a bit of a higher cost of living as well. So, which is Toronto for most people know about Toronto, and the cost of living is higher. So the increase in pay did also get affected by the cost of living, but the when you balance all things, this job still came out on top in terms of the financial benefit. And that was important to me as well, as it should be to some degree. It was not number one for sure, but it was a factor. So some responsibilities in family medicine clinic, I named a few, but just to get an idea, you see patients the way that a doctor would. You take a history, you do an exam, you can order investigations, you can prescribe medications. Again, this is all in the direct or indirect supervision of a doctor. In my case, I worked with 4 different doctors. So I'd work with one on each day, essentially. We order a lot of tests in the family medicine clinic, and those test results come back, and I would, on certain days, review those test results and call patients and tell them what results they needed to know, or give them, or set an appointment up for them to come back to get the results, or if there was something wrong, to prescribe a medication. If someone has a urinary tract infection, to send a prescription off to treat that. These are procedures, like I said before, that I was doing, and preventative care. So things like your pap smears, doing colorectal cancer screening, doing breast cancer screening. These screening tests, I was also helping organize them for patients as well, which is, again, a very important part of medicine, to catch these things early. And then also referring people and reviewing consult notes. So if a patient needs to see a specialist, sending them off to the specialist, and the specialist will write us a note saying their opinion on what's going on with the patient and what their recommendations are. And then we take those recommendations and implement them. So that was family medicine. In the ER, again, I talked a little bit about it, but similarly, we see patients. We at least start the patient encounter. In family medicine, I would see patients and send them home without the doctor seeing them. I would review all the patients that I saw, and maybe usually at the end of the day or at lunch, but they didn't have to see the doctor. They just could see me and go. And there was a lot of PAs will have their own roster of patients even. This this set of patients, they are always seeing the PA. So there's more continuity of care. So even though they're not technically your patients, they're still the doctor that you're working with. It's their patients, but you are their provider. They see you every time. And that can be a reality for PAs in family medicine. In emergency medicine, however, usually almost all of my patients will also see the doctor at some point, even if it's just to say hi, to put eyes on the patient. I think medical legally it's the case, and also for billing purposes, they have to do that as well. But depending on the acuity of the patient, if they're very sick, and then the doctor will be more involved. But if it's a very quick thing, then they may not be involved at all. So I order tests and prescribe medications as well in the emergency. Again, I'm doing this with the cosign of the physician that I'm working with. But I can put those orders in and they will be carried out before the doctor even sees the patient. But again, I'm always reviewing the orders that I'm putting in with the doctor, either after I put them in or before I put them in. Procedures. So like I said before, I'm doing lots of, I stitch someone up. If I don't stitch someone up in a shift, then it's a weird day. I almost always do. And same thing with casting is pretty common as well. It's one of the most common things, putting on cast for the arm, for the foot, for the leg. Reduction, so reducing is when there's a broken bone, it's moved out of place. Sometimes it needs to be pulled back into place. So I help with those, or sometimes perform those, or someone has dislocated their finger, or dislocated something simple. I can just yank on it and put it back into place. Incision and drainage. So if someone comes with an abscess or a cyst, then I can drain those as well. And all of these procedures are independent, other than reductions, which require the patient to be under conscious sedation, meaning we give them medication to make them fall asleep and not remember what happened. We need a doctor to be administering that. And usually it's me and a doctor doing the reduction, and then I put on the cast. Similarly, in family medicine, we also order tests that sometimes come back later, often like cultures. They take a couple of days to come back. And so I review those as well and see, is there anything, does a patient need antibiotic now, or do they need to come back to the hospital to get reassessed, or they're fine, they can just follow up with their family doctor. I follow up and call patients or act on these results as well. We consult specialists. So if a patient is really sick and needs to be seen by surgery or medicine or another specialty, we will call them up and tell them about the patient, and hopefully they come down and see the patient, and we can discuss the plan together and how to take care of them. Disposition is, what happens when the patient's done their visits to the emerge. Where should they go? Should they go home? Should they go back to their nursing home? Should they be admitted upstairs? These are decisions that we have to make in the emergency department, and it's an important part of it as well. Some patients don't have a home to go to. Some patients are without a home, so we have to help them find some type of place to go stay, usually a shelter or something like that. And then we get people involved, like social work and whatnot, in those instances as well. So in terms of, I don't have cases, because I think before doing cases, the base thing that I think for most PAs and any kind of person going into healthcare, I think maybe 75% of healthcare is your history taking, your physical exam, and you're making a plan. And obviously a lot of stuff goes into that. You still have to know your clinical knowledge. You still have to know the different diseases and what investigations you would order and what medications would be appropriate. But if you can gather information really well, that's one of the most important steps in medicine, is gathering information, because without information, you can't make well-informed decisions. So informing yourself of exactly what's going on, what's wrong with the patient or what they're feeling, and what has gone wrong in the past, what's their past medical history, all of these things will shape what you do next. And in emergency medicine can definitely, potentially save someone's life. So I wanted to talk about that a little bit. History taking. So patient comes in, they have a complaint. The more common complaints that we see are things like chest pain, abdominal pain, headache, dizziness, fatigue, or pain in the limbs. Nausea, vomiting, fever, diarrhea, pain with peeing. These are common chief complaints. Chief complaint is your main complaint. And then there's associated symptoms involved with that chief complaint. So I have stomach pain. Okay. Do you also have diarrhea? Yes. Do you also have vomiting? No. Does it hurt when you pee? No. Do you have a rash? Do you also have a fever? What are the other symptoms that are associated with your chief complaint? And then it's understanding those symptoms and having a clear picture of what that symptom means to that patient. So I like to use this abbreviation. Most people use OPQRST. I was once shown this, LMNOPQRSTUV, which is the alphabet if you're familiar. If you're not, then I don't know what to tell you. L is for location. So where is the pain exactly, or where is the symptom? This is more commonly used for pain, but it can be used for other things as well. But we'll stick with pain. Where is your pain? Mechanism. How did it happen? Was there a specific thing that happened? If your ankle hurts, did you roll your ankle? If your head hurts, did you hit your head? If your stomach hurts, were you, or your chest hurts, sometimes you're in a car accident, your seatbelt pushes on your chest and causes your chest to hurt. So understanding exactly what happened before this. Or your stomach hurts. Did you drink a lot of alcohol? Or did you take a lot of Advil? Or something like that. Well, knowing the events that preceded the pain is important. Noise. This is very just more specific to MSK stuff. So if you rolled your ankle or if you fell down, did you hear a crack? Did you hear a pop? Did you hear any noise that could indicate injury? Onset. When did this start? Very straightforward, but it is one of the most important questions. Did it start an hour ago? Did it start 3 years ago? It changes entirely depending on when it started. It changes your differential, I mean. Palliating and provoking factors. So palliating would be what makes it feel better. Are there certain medications that you've tried that make it feel better? Does laying down make you feel better? Does twisting your body in a weird position make it feel better? Does humming make it feel better? What makes it feel better? Because if we know what makes it feel better, then we can that gives us a bit more information about what it could be. What makes it feel worse as well? So does, after eating, you start to feel better? That would be interesting to know why. Or after, let's say, taking a deep breath, does taking a deep breath make it worse? Does it make it better? Just again, all of these things are giving you more qualifying factors as to what the pain is and where it might be coming from. The quality of pain. So what does it feel like? Is it a sharp pain? Is it burning? Is it aching? Is it an electrical pain? What does it feel like? Radiation, does it move anywhere else? Does it go up? If you have chest pain, does it go up into your neck, to your shoulder, to your back? If you have foot pain, does it go all the way up your leg, or does it just stay in your toe? Severity. On a scale of 1 to 10, how bad is the pain? 10 being the worst pain you can imagine. Timing. Does it come and go, or is it constant? Does it happen more in the morning, more at night? Does it happen only when you look at the sun? Whatever timing aspect. What is your understanding of the pain? Have you had this before? Do you know what this is? Are you have gastroesophageal reflux disease and you have it all the time and this feels just like that, or it feels nothing like that? That's good to know, because if you know if you've had it before, that increases the likelihood that maybe that's still that same thing. But if you've had something before and this feels different than that, then it probably isn't that thing. And then your value. So some people they're here with pain and they just want to get rid of their pain. They're just like, my back's been hurting for the last 6 months. I just want some pain medication. I don't want anything else. That's what they care about. Some people say my back's hurting and I want to know why it's hurting. I want to get I don't need any medication. I want to know why. So understanding why they're there is also important. So that's those are 11 questions that you can ask to a patient. And I think that gives you so much information right off the bat. And then, of course, knowing their past medical history, their social history, what other conditions have they been diagnosed with? Do they smoke? Do they drink every day? Do they do drugs? Do they live? Do they, if it's a child, are they in daycare? Are they seeing other people all the time? Have they traveled? Have you had, what kind of diet are you on? Things like that also can help you with your understanding of the patient. What medications they're on, of course, will make a huge difference. Sometimes the reason that they're there is because their medication is causing them symptoms. And then if you know that, or if you are aware of that, then you can solve the problem pretty easily, is stop taking that medication. Or let's switch it to something else. Have they had surgery before? That's also a big thing. If someone has had surgery before in their abdomen, it makes it higher likely, increases the likelihood of them having a bowel obstruction. So if someone hasn't pooped and they have a lot of abdominal pain, asking if they've had surgery before is an important question. And then, for recent travel, it's an important question because there's different diseases out there in the world, and some are only endemic or more common in certain countries. And so if they've been to that country, it's important to know that. Yeah, good questions. Good job. We're still good for questions, Michael?
Yeah, right now, no questions. One thing that I might want to ask is, you discussed why you decided PA over being a physician. Did you consider any other routes, like being a nurse practitioner, any other similar provider roles that are just down a different training route?
Yeah, I initially, I didn't know about PA. So in Canada, like I said, PAs are not very common. And I just happened to come across a profession at one point. I initially wanted to go into medicine because that's all I knew. I knew I wanted to work with people and the human body, and help people in that way. So I thought, okay, I guess medicine's my only path. So, and of course, it's not the only path, but naively, I thought that I was. And I didn't really look into other things until later on. And during my last year of undergrad, I was like, okay, well, maybe I should look at other stuff. Maybe I shouldn't just, bank my whole life on this one thing. And I looked into other things. And I think the other things that I considered were also physiotherapy, because that's a common pathway for people in kinesiology. It sets you up perfectly for physiotherapy, because that's usually what the program is geared towards. But I knew that I wanted, again, I had such a wide interest that I knew I didn't want to just be focused on the MSK side of things, the musculoskeletal side of things. I also wanted to know about the heart and the lungs and the GI system, and we do learn about that in physiotherapy, but your treatment is a bit limited to just usually physical treatment, physical manipulation, and things like that, and exercises. Whereas in medicine, you have a larger array, a larger arsenal of treatment and investigation. Nursing, I have the utmost respect for nurses. I think they have some of the hardest jobs ever, and they deal with so much. And they are often taking the orders from the physicians, what medications or investigations to order, and are carrying those out. And I think for me, I wanted to have a bit more of the puzzle solving aspect of it, which was, collecting information and then making a plan as to what to do next. A lot of nurses do that to some degree as well, but I think that the doctors and the physician assistants do that to a bit of a higher degree in terms of the medical decision making. And being a nurse practitioner would be also another option to make medical decisions. A lot of people, instead of having a family doctor, have a nurse practitioner or NP. That would require you becoming a nurse first, of course. I think in Canada, at least, NPs usually are seen in family medicine, but they can work in other specialties. From my personal knowledge, I see PAs being having a wider array or wider options in terms of what specialty they can work in. So you can often see PAs in the OR helping and first assisting, whereas I don't see that as often with NPs. And I might be wrong about that, but from my personal experience, I knew that part of me maybe one day wants to do that, or would be at least like the opportunity to do that. And so, I think those are the reasons. But yeah, it was very, it happened through, I think, mostly luck and happenstance, but I knew I wanted to practice medicine, and there's not that many jobs that allow you to practice medicine specifically, but PA does.
Sounds good. Thank you.
Yeah, no problem. So I think history taking is probably the most important, and then its physical exam is your second most important. And these are just the different systems of your physical exam. So your neurological, your brain, the cranial nerves, the peripheral nerves, um, the association between those two, and making sure that everything is functioning that way. Ear, nose, and throat. It's very common for upper respiratory infections, checking the ears, checking the nose, checking the throat. Lymphatic also for similarly upper respiratory infections. Someone has a fever or their lymph nodes swollen. That's an important thing to know. And then cardiorespiratory obviously is very important. Almost every patient, unless it's an MSK patient, almost every patient has listened to the heart and lungs because you never know. Abdominal, that's a very, again, I would say cardio, respiratory, abdominal, and neurological are the most important exams I do every day. Pushing on someone's stomach and it hurting in one specific area will change my entire management very easily. Someone says they have abdominal pain, I push on their right lower quadrant and it hurts a lot. I immediately now I'm thinking of appendicitis, and now my treatment or my investigations will change. Versus I push in that area, it doesn't hurt at all, but it hurts a lot right in their epigastrum, which is just the area below your sternum. Now I'm thinking about more stomach, thinking about more gallbladder, pancreas even sometimes, but now I'm thinking in that area. So it changes what your differential is or what's higher on your differential list. Genitourinary, so for rashes or for lesions, or if someone's having heavy menstrual bleeding or vaginal bleeding, doing that exam and is really important to know exactly what's going on, and obviously being aware and sensitive to that exam. And then a very common one in the emergency is musculoskeletal. Having a background in kinesiology was really helpful in being comfortable doing that type of exam and knowing what specific exam maneuvers you can do to figure out what the problem might be. And then dermatological is always, I think, a difficult one because there's so many different types of dermatological diseases. There's I'd say a few handfuls of ones that are more emergent, but a lot of them we kind of throw our hands up and say we don't know and have to refer to a dermatologist for. But having a very comfortable, efficient, and comprehensive physical exam, again, is, I would say, it's interesting because I think people are now starting to replace physical exam with investigations. They just do ultrasound or something like that instead because the physical exam is not perfect. Sometimes you push in the right lower quadrant and you're like, this is probably appendicitis. You do the test and it's not. So it's some people might not do it as much, but I think it's still irreplaceable, or it's you can't switch it out with something else and tantamount to your assessment. And then investigation. So what do you want to order? Now, I think in the emergency department, everything becomes quite algorithmic. So if someone has chest pain they have chest pain inside their chest, not that their ribs are hurting, but somewhere inside their chest, they have chest pain. And it's been like a short period of time. Almost every time we will always do those same tests, which is routine blood work, a troponin, which is your heart enzyme that gets released when you're having heart damage during a heart attack, and an ECG. Doing those things are almost reflexively. Sometimes that happens before you even see the patient at triage. So there's kind of an algorithm to things. If you have this symptom, you probably will get these tests. So your chest pain, you'll often get that. Often, if they have any respiratory symptoms, you often get a chest X-ray. Again, not every time, nothing is absolute, but there is likelihoods of certain things. If they have abdominal pain, especially epigastric pain or right upper quadrant pain, they'll get liver enzymes done. Electrolytes are almost always important, so those are almost always ordered as well. CBC is your complete blood count, so your hemoglobin, your white blood cells, your platelets. It's also important to know if someone's bleeding or they're really fatigued, they could have anemia, so you want to check their hemoglobin. If someone has a fever and their white blood cell count is very high, then they likely do have an infection or something bad going on. If someone is bleeding a lot, maybe their platelets are low, and that should be checked as well. And then, like I was kind of mentioning it already, but your imaging, so your X-rays, usually chest X-ray for respiratory symptoms, Abdominal x-rays are not often used. That's what AXR means, abdominal x-ray. CXR is chest x-ray. Abdominal x-rays are not very commonly used, but they can be useful in certain instances. But more often, people will be ordering abdominal ultrasounds or abdominal CT scans. If someone has hit their head really hard, or they're on a blood thinner and they hit their head, or they're having a really severe headache or a lot of dizziness, we might do a CT scan of their head, a CAT scan of their brain to see what's going on, or a CTA or a CT angiogram, which is when you inject dye to see the vessels in the brain to make sure that they are patent, that they're open, that they don't have a clot, they're not having a stroke. MSK X-ray, which would be, your broken bones, your dislocated joints, things like that. CTPA is a specific CT of the chest to look for it's a CT pulmonary angiogram. So if you're worried about a pulmonary embolism, which is a clot in the blood vessels in the lungs, then you would do that test. So there's many more blood tests, many more imaging tests, obviously, but these are some of the more common ones. Cultures are very important. So urine cultures to see if someone has a UTI, blood cultures to see if someone has blood in their, some bacteria in their blood, wound cultures to see if someone's growing specific culture, specific bacteria in their wound, throat cultures, again, for like strep throat, things like that. Those usually take a day or two to come back. There are some rapid swabs as well, but they guide your treatment. It's important to know what bacteria someone is growing because there's certain antibiotics that are more well suited for that bacteria and some that are not, some that the bacteria will be resistant to. So you give the antibiotic, they don't get better. So you have to, doing the cultures is very important. And if someone has bacteria in their blood, that can be fatal. So they have to, that usually comes back in a day or two. So you have to call the patient back to come to the hospital. And then kind of other types of swabs, viral swabs, your COVID swab, your respiratory swab, things like that. And then treatment, again, very, very, very general, very broad here, but obviously your medications, again, is almost algorithmic for the emergency department, at least. If someone's vomiting, you give them medication to stop vomiting. Someone's having pain, give them a medication to stop pain. And those are usually the most two common. But if someone, even with dizziness, dizziness, you can give medication for dizziness to help with that. And those are probably the most common complaints is I'm feeling nauseous or it's hurting or I'm really dizzy. Fluids, giving, hydration is key. Hydration is number one, always stay hydrated, drink your water. A common thing you'll hear is that the color of your pee should be a very light, pale yellow. If it's a dark yellow, then you're likely dehydrated. So check your pee, I guess. Fluids are helpful for sure. If you're feeling really lightheaded or if your blood pressure is very low, it can be helpful. But if you're overloaded with fluid, then it's not good. And then some people we will stitch up. And I do a lot of stitching. There's a lot of different types of stitches that are required. If it's just on your limbs or somewhere easy, you can throw those stitches in relatively well. But hands and face get very complicated, and ear, they're very intricate, they're very irregular, and so getting stitches takes a bit more time. I've done a lot of interesting stitches. I think a lot of my interesting stories are usually about stitching people. I've had people where the skin on their finger, it's called, I don't know how graphic I'm allowed to be on these.
No worries. Go ahead.
I've had patients where the skin on their finger, it's called degloving, because when you take off a glove, the glove goes inside out. And so someone's skin was torn and their skin was inside out the other way. And so it's doesn't happen very often, but it does happen. And so we had to flip the skin back onto the finger and then stitch the skin back on. And they all obviously have to go see a specialist and everything. But you don't do that too often. Someone's cut their ear in half and I had to stitch their ear back together. Someone's had chunks of their face bit out by a dog, so like a big chunk of their lip, their own dog unfortunately ripped it out, and I had to do what I could to make them pretty again, and it's not easy, and once you get a cut, it will never look the same, so you do what you can. But it is an art. There's an art to it, I think, and you can only get good at it from practicing. And I'm a year and a half into emergency medicine, but I stitch people almost every shift. So I've had a lot of practice, but I'm still learning, still getting better, still seeing stuff that I haven't seen before and solving novel problems. But it's something I think relatively passionate about getting putting in good stitches, especially for faces, because you will have that scar for the rest of your life. So if it's not well done, then it'll be more noticeable. And then, yeah, sometimes you have to stitch. Sometimes someone there's other difficulties with stitching. If someone has a deep cut, they might be bleeding profusely. So now you are working in a very bloody field, and it's hard to kind of feel like you're working under pressure. All this blood is coming out at the same time as you're trying to do a job. So it's definitely a skill that you can only get better at by practicing. No matter how much you read or watch videos on, you have to just do it over and over again to get good at it. Casting is, I think, relatively simple. I mean, there's a handful of casts that I do repeatedly, and it doesn't matter too much about how broken something is. The cast will be about the same. And then surgery. And when I say surgery, I more so mean setting them up to surgery. So if someone needs surgery, consulting the specialist, saying, "Hey, this patient has this, and this," they might be a candidate for surgery. The surgeon might come down and take them to surgery. And if they don't need surgery, or they do need surgery and they need to stay after that, or if they're just really, really sick and too sick for the emergency department, we will call the medicine team, the internal medicine team, to admit the patient, meaning that the patient will now be staying overnight. They'll usually go up to the floor, to the ward, to stay there. So even in emergency medicine, there is a limit to how much we can do, or how much care we can provide, and we have to send them upstairs at times. Resuscitation is something that I work in a more city center hospital in Toronto, and there are a lot of doctors and a lot of people there. So I don't often, I'm not often in the resuscitations, because those resuscitations are quite labor intensive and take a lot of people away from the rest of the department. So I tend to stay back and continue to see other patients that are waiting, because if we all go there, then all the patients that are waiting don't get seen. So PAs, at least in the urban centers, often are not running resuscitations or part of resuscitations or traumas or things like that. That's usually run by the doctors. PAs can obviously assist in that, but I think they tend to be more useful continuing the flow of the department while the doctors are busy with that. But in smaller hospitals and rural hospitals, that might not be an option, because if you have a smaller amount of staff, sometimes the doctor is too busy. If there's two resuscitations that come at the same time, then the PA might have to take over that role and provide guidance or be the leader for that resuscitation. Resuscitation meaning someone is coming in without a heartbeat, or they're not breathing, bringing them back to life, or trying to. So this is a very just kind of informal, basic introduction to PAs and what we do. And what emergency medicine looks like on a typical for a typical PA, I'd say. And I think just overall reflections are that I think most people want to help people. I think it's a natural inclination that most of us have. And like I said before, most jobs will allow you to help someone in some way. It's just finding something that you're also interested in that will pique your intrigue enough to want to learn more about it and get good at it to the point that you can actually be helpful. And so I chose medicine, I chose healthcare. And if you've also chose that, then that's great. But there are multiple avenues that can get you there. So whether that's medicine or PA or nurse or nurse practitioner or physiotherapist or social work or mental health therapist, there's so many avenues for that. And it's worth looking into all of them. But I think you have to first think about yourself and what you want in your career, what you want your career to look like, what you want your life to look like. And does that match? Does the job that you're thinking about match that? And that takes a lot of reflection and understanding your values and what is important to you. And I think sometimes we just pick something without thinking and go for it. And I think you can learn a lot by doing that. But I think reflecting before making big decisions is also important. Is this something that you want, or is this something that you think you should want? Is a good question. And I think stuff like this is great, hearing from other people and hearing about their experience and what their reality is super helpful. And then speaking to them as well. I mean, if you have specific questions after this or want to talk one-on-one, I'm always open to that too. I do have an Instagram page that you guys have shared as well. It's safinous.pa, SAIFENOUS.PA on Instagram. You can message me there if you want to talk. I'm always trying to answer messages and sometimes even have little Zooms to just discuss things or chat about life or whatever you want to chat about. I'm always down for a chat. So yeah, that's me. And if you have any questions, I'm here to answer.
100%. Well, first of all, thank you so much, Saif, for getting this presentation together. These are some great insights, and like you said about some of the cases, some of the sutures you've had to do before. Emergency medicine does get a bit graphic. The last time we had emergency medicine on, or at least one of the recent ones, there was a case about maggots in someone's head after they got their head split open. So yeah, it does get graphic, but makes for quite a few stories. Like you said that those are the stories when you have those sutures. So we want to first of all thank you for taking the time to get this all together. We do have a few questions just before we wrap up. So the first question we have is, and you touched on this a bit before, how in Canada specifically, there's only around 1,000 PAs, and that's relatively a small number. So some patients, with that said, might not necessarily know what a PA is, or even if they do, they might not necessarily be comfortable having care from a PA in place of a doctor. How do you typically approach those situations?
Yeah, it's a pretty common question. A lot of people tend to have concerns about that. Interestingly enough, I thought I would have a lot of pushback coming into working. I'll stop sharing here. I thought I would have a lot more pushback from patients when I started working. And I honestly can count probably on two hands the amount of times, or maybe even one hand, the amount of times that people have actually refused to see a PA. The most that I'll get is, oh, sorry, what did you say you are? A physician? What is that? I've never heard of that. And then I explain what it is, and they're usually like, oh, okay, well, this is why I'm here today. And that's, I'd say, the majority of cases. Very few and far between is they're resistant entirely to the idea of not seeing a doctor. And so I think, especially in emergency medicine, they usually are just happy to be seen because they've been waiting so long, or they're worried or concerned. And so they don't seem to have a problem. And I think it's also how you come across, right? If you come across as someone who's not sure of themselves, or is really nervous or scared, or unsure of what to do, or how to interact or be or give support or reassurance to this person, then they will be more uncomfortable and may want to see somebody else instead. So I think it's how you present yourself is really important. And then just knowledge, information, explain to them what a PA is. I think what I usually say is, I'm a physician assistant. We help doctors by doing a part of their job for them. And that usually is enough. And then if they want to know more, I will go into more and I'll explain the schooling, or I'll explain, what exactly we do. But most people are receptive to that. And I don't usually have too much trouble. So, yeah.
All right. And another student asks a question that kind of bounces off or goes along with the point that you mentioned earlier, going through the types of imaging. So you said abdominal X-rays are not commonly used. Why is that?
Yeah. So, the abdominal X-ray, from the X-ray, the information that you can get from the X-ray is limited in terms of what you can see. So X-rays are great for bones. You can see what bones look like. They're good for seeing a snapshot image of what's going on. So for example, A CT scan is 300 to 1,000 slices of an X-ray. So you can actually see each layer of the abdomen and what it looks like. Whereas an X-ray is just a flash image of one image, right? And so you get a general picture of like different densities of things. So bones are more dense, you'll see them a bit more, whereas air isn't. And so then when you look at the lungs, you see a lot of blackness because there's air in them. The bowels, the abdominal X-ray is good for the bowels, but you can't see the gallbladder really well on the abdominal X-ray. You can see the liver a little bit on the abdominal X-ray, but you can't see that many features about it. You can see maybe its size to some degree, but the appendix you can never see on the X-ray. All you can really see on the abdominal X-ray is most bowels. So if you're concerned that someone has a bowel obstruction, sometimes the bowel gas pattern in the intestines can indicate an obstruction. So if you see a sudden cutoff in the bowel gas, then you'd be suspicious of obstruction. But then you do a CT scan anyways, because you need a better image to actually see where the obstruction is. So obstruction sometimes it's useful for, and then if you are concerned of like free air in the abdomen. So if you think there's a perforation or something like that, there's a chance that there's a hole in the bowel, and now air is somehow getting out of the bowel into the space surrounding the bowel. That becomes obviously a very urgent case. They need surgery right away. You would see the air inside the abdominal cavity. And it would be kind of up at the top of the diaphragm because air rises, and you'd see kind of a layer of air. But again, like if you are that concerned of a perforation, you'd likely do a CT scan because it's just a better image. Obviously, maybe we're obviously privileged and we have CT scans that we can do pretty readily. And so some places might have to rely on their abdominal X-ray much more, and that might be true. But the other thing is ultrasound, right? If you're worried about gallbladder, for example, the best test for gallbladder is ultrasound, because you can actually you can compress the gallbladder and see if it's compressible. You can see its flow, is it obstructed, things like that. Same thing for uterus and ovaries. The ultrasound is usually better for that as well. If someone's pregnant, want to see what's going on there, ultrasound's your choice. And for appendix, sometimes ultrasound, but CT scan's usually better, but appendix abdominal X-ray would not be useful for that. So there's much less use and much less information that you get from an abdominal X-ray compared to the other options you have of ultrasound and CT scan. And so some doctors I find almost never order one. And because I work with so many different doctors, I work with maybe 50 doctors, because it's an emergency department. There's always new doctors coming in and out. Most of them, we very rarely order abdominal X-ray. If we think someone's very constipated, sometimes too, you can see stool in the abdomen, in the colon. And that can tell you if someone's just backed up, a bunch of poop. But you can tell if they haven't pooped in 3 days, then you can probably imagine that they're full of poop. So you might not need the X-ray for that. So yeah, that's the reason. But again, everyone practices a bit differently. Some people might like to use it more, and that's the other kind of interesting thing about medicine is everyone practices a little bit differently. But there's obviously also the kind of best practice or what is most researched as well.
All right, and one more question to wrap up today's session. So you mentioned having a spontaneous personality and how that led you to emergency medicine. A student asks, do you believe having a spontaneous personality might in some ways affect your practice in certain specialties? Do you think that has been the case for you or any other colleagues?
Maybe. I think that at least for me it did, because I like to feel a little bit I don't know if uncomfortable is the right word, but I like to feel challenged constantly. I don't like to feel too comfortable in my job to the point where I don't feel like I'm learning or that I don't feel like I'm testing my knowledge. Family medicine, there are challenges, don't get me wrong, but a lot of the patients that you see will be relatively straightforward. You can handle them within 10 minutes usually. And it's often like, okay, how are you doing? Let's check your sugars, your HbA1c. Okay, it looks good, or it looks worse than last time, or it looks better than last time. Great, let's do, it's worse. Let's do this, or more exercise, or increase your medication. Sounds good. We'll see you in 3 months. Or high blood pressure. Your pressure is too high. We're increasing your medication. Or your pressure is great. Keep at it. And those are just like very common things that you would see. And I think being this early in my career, I'm still hungry for knowledge. I'm still hungry for like learning new things and feeling like I don't know a lot, I still don't know a lot. But I like that kind of feeling of there's more to learn. There's more potential to learn. And family medicine still has that, but I think emergency medicine, like there's still so much, right? And even though there are common things that you see every day, any of those common things might have actually been a more dangerous thing. And so you're always staying vigilant, you're always learning, you always are seeing new and complex or intricate or unique cases. And I think, yeah, for me, it scratches a certain itch of novelty. And I get to work with different people every day too. Like it makes the day just feel different. Whereas if I feel like I'm having the same day over and over again, personally, I feel like robotic or repetitive or monotonous. And so I think there's other specialties will allow you to do that, especially when you're working in a more acute setting or more with sicker patients. But if you are working in, say, something very specialized, like hematological oncology, for example, it's very specialized. You'll see very much the same thing over and over again. And if your type of personality is someone who likes to hyper focus on one thing, get really well versed in one thing, then it makes sense for you. But if that's not the case, then it doesn't.
Well, that is definitely a great point, and I think that's a great way to end off today's session. So first of all, thank you again, Saif, for getting this all together. These were some really great questions. Great job, guys, with these questions, and again, great answers. I do have a quick reminder for those who are listening in for our shadowers today. If you would like to earn credit for your attendance, we have a quiz that's now posted in the chat box. That quiz is also on our virtual shouting page, and it's also under the video description. So there's 3 places that you can access it. All the same quiz, though. It's a Google form, 10 questions, and you have to have 6 or more in order to pass, 6 correct. And we'll send over a certificate if you do pass. That certificate should be sent to the inbox email of the address that you list, the email address that you list. So we do recommend a personal Gmail or Yahoo address. It will be due this Sunday, July 9th at 11:59 p.m. Central Standard Time. So definitely be sure to have it done before then. And if you have any questions, as always, feel free to contact us. Our email is community@hearts4health.org. We'll also be joined with another speaker, another PA, working in trauma surgery this time on this Thursday, July 6th at 7 p.m. Central. So definitely looking forward to that. We'll be posting the flyer pretty shortly. So definitely check out the details on our Instagram if you're curious to know more about our speaker. As always, we have our Instagram page, like I mentioned, and our listserv. It's great ways to stay in tune with us. Saif also has his Instagram handle. I know you might have shared that earlier, but do you want to share it one more time?
Yeah, I will. I'll just type it here too, but it is at safinus.pa, SAIF, F as in fire, EN as in November, OUS, .pa. It's a play on the great saphenous vein for those who are biologically inclined, I guess.
Sounds good. We also have it on our flyer, the one that we sent out on Instagram. So you can definitely feel free to check it out there at the very bottom of our caption. But that is all for today. I hope you all enjoy the rest of your evening. Enjoy your 4th of July. I know that's more of an American thing to say, but enjoy the rest of your week, y'all. I know that it's a summer, and I know quite a few of y'all are going through, whether in PA school or hoping to go to PA school or hoping to go to med school. Y'all are in the application cycle. So always wishing the best for y'all. But other than that, again, thank you so much, Saif. Well, let's hear some thank yous in the chat for him. But that will wrap it up. I hope y'all enjoy the rest of your evening. All right. Take care.
Thank you for